So on behalf of the Obesity Society, welcome to today's briefing, examining the safety risks of compounded GLP-1s. I'm Dr. Catherine Saunders, and my expertise is in medical management of obesity. I'm one of the first physicians in this country to be fellowship trained in obesity medicine. I'm on faculty at Weill Cornell Medicine in New York City, where I've been for 18 years, and I'm the co-founder of Flight Health. I also serve as the chair of the Obesity Society's Communications Committee. Since we have a diverse group today, I just want to take a step back and kind of level set, since we range from people who've been in this field for many, many years to people who may be hearing about obesity for the first time. So just to put everything in context so that people can appreciate kind of the issues at hand, just want to take a step back and talk about what obesity is for a couple of minutes. It was long thought that obesity was a personal failing, a lifestyle issue, or the result of simply eating too much and exercising too little. We know definitively, based on science and research, that obesity, in fact, is a very serious, chronic, complex disease that is really difficult to treat for many people. It is not curable, but it is absolutely treatable, and we're very fortunate to have not a huge, but we have a number of tools in our toolbox to help our patients. The medical management of obesity is absolutely critical for most people to be able to manage their obesity effectively long term. We have a range of meds, some of which are the GLP-1 receptor agonists, or medications that include the GLP-1 pathway. I can assure you that these medications are absolutely not a crutch or a nice to have, but they are absolutely essential for many, many people to treat their disease. And when these medications are prescribed appropriately as part of personalized comprehensive care, these medications can be life-changing and life-saving. As a clinician innovator focused on improving access to very high quality medical obesity care, I witness every day firsthand the promise of these medications, but also the risks of what can happen when non-evidence-based approaches are used. Whether you're here today championing health policy as part of a congressional office, or you're another stakeholder, we really appreciate your being here to learn the differences between FDA and compounded medications and the issues surrounding this topic. We're here to build awareness, examine data, discuss how regulators and clinicians can collaborate to protect patients, and to explore policies needed to ensure that medical treatment is based in science, that medical treatment is accessible, and that medical treatment is safe. The briefing today is actually part 2 of another briefing in March that was held by the Obesity Society that was more of an introduction to the topic. Since then, there's been continued advocacy by many, many organizations to work on ensuring that consumers have access to safe medications and can make informed choices about their care. The Obesity Society is the leading professional society focused on obesity science, prevention, and treatment, and we are really proud to host and to serve as a resource for everybody in this room. So let's get on to the panel. We have a lot to discuss today. I'm going to start by introducing our panelists. Joining me today are Peter Pitts. Peter is president and co-founder of the Center for Medicine in the Public Interest. He's a former member of the United States Senior Executive Service and an associate commissioner of the U.S. Food and Drug Administration, where he served as senior communications and policy advisor to the commissioner. He served on the agency's obesity working group and counterfeit drug task force. Next, I have Dr. Ray Serrano. He serves as Director of Research and Policy at the League of United Latin American Citizens, where he leads a bold expansion of research-driven advocacy. The son of migrant farm workers from Idaho, Dr. Serrano holds a BA from Stanford University, an MPH from Yale, and a PhD in Health Services, Research and Health Policy from Emory. He's held pivotal roles at the World Health Organization, the Centers for Medicare and Medicaid Services, and the United Nations Development Program. Whether shaping policy in Washington or advancing equity on the global stage, his work reflects a clear mission to center the voices of underserved communities in the nation's defining health and civil rights conversations. Finally, I have Dr. John Hertig. John is a former faculty and past chair of the Pharmacy Practice Department in the Butler University College of Pharmacy and Health Sciences. He's a member of the United States Food and Drug Administration Drug Safety and Risk Management Advisory Committee. He holds other national and international appointments, including the past president of Alliance for Safe Online Pharmacies Global, where he led efforts to reduce the patient safety impact of illegal and counterfeit online drug distribution worldwide. John, I'm going to start with you. So this issue of compounding medication is not something that's new. Medications have been compounded for a long time, but this is, in the recent past, the first time that many people are hearing about compounded meds in relation to the GLP-1 medications. There's a lot of confusion, which is one of the reasons why we're having this panel today about, what is an FDA-approved medication versus a compounded medication, brand name, generic. John, we would love to start with you to go over the basic definition of compounding in pharmacy practice and why it's necessary.
Great, and thank you for the invitation. It's a pleasure to be here. I'm glad you asked the pharmacist what compounding was. Compounding is essential to pharmacy practice. It's been so since the dawn of pharmacy, really. Compounding basically is when you're mixing products together, changing the formulation of a product, maybe combining products, doing so that patients get something that they need. And it's been around for a very long time and continues to this day, both in the community as well as in our hospitals and health systems. Now, compounding, though, is not an FDA-approved practice. That's when our drug manufacturers come in. And when we're looking at trying to get a product, a medication for yourself, for your family, the gold standard would be a manufacturer, an FDA-approved manufacturer. Now, that's not always available to every single patient. I'm thinking about our pediatric populations. There may not be a dose that's suitable for a pediatric patient, and so you get a compounded medication that's suitable for that patient. Or maybe you're allergic to a dye in a medication, or an excipient, or a non-active ingredient. So you have your active pharmaceutical ingredient, your API, that's the thing that makes it work, but then you have binders and other products. You might be allergic to that, so you need it to be compounded. Even going into flavoring, your kid spits up a medicine because it tastes gross, and they go flavor it. These are all part of compounding. But it's not FDA approved, and again, that gold standard would be the FDA approved product. It's also necessary, and we see compounding particularly with the GLP-1s, and that's why we're talking about it here, is that compounders can make a product when it's on, say, shortage, the FDA shortage list. And those compounders serve a really important role because if something is on shortage, as the name would suggest, you can't get it from an FDA-approved manufacturer. Well, our compounders step in and help maintain the supply of that particular product, which serves a really important role. And so that shortage is another area or reason why compounding may occur on a much larger scale than what we see traditionally in a community pharmacy or in a hospital or health system setting.
One question I get a lot from my patients, John, is how would you compare compounding to generic medications? I think that's an area of confusion for some people.
Of course. So a compounded medication is not a generic medication. A generic medication is essentially the molecule of the branded medication. We know our branded medications through FDA-approved manufacturers have a patent life. Once it goes off patent, you can then make a generic medication, but that's still made by traditionally a generic manufacturing company that's submitted an abbreviated new drug application to then get approved by the FDA to make that generic product. That's very different than what we would see in compounding.
Thank you for the great description, and I'm glad we called on the pharmacist first to explain, FDA approval is a long process, and the generic medications are part of the FDA approval process, whereas compounding doesn't have the same level of oversight. And so a few years ago, when the GLP-1 receptor agonist became so incredibly popular for diabetes and obesity, and everyone was going crazy to get these medications, literally the pharma companies could not keep up with the demand, and that is what led to the shortages. And maybe there's some people in the room, I certainly as a clinician lived through the period of shortages and helped my patients get through that. And luckily, we finally got to the point earlier this year where the FDA declared that the shortages were over. But we still see that compounding medication is everywhere. And so why is that the shortages are over, the compounders are not supposed to be still producing the compounded versions, yet literally every corner we see a MediSpa, and online we see so many online platforms. What is the disconnect here?
Well, first with shortages. Shortages are a huge issue, both here in the United States and ex-US. There are over hundreds of medications that are on shortage. Now, thankfully, GLP-1s are not one of them anymore. And what that means is that the FDA, you should go to the FDA source. You should not be compounding it unless there's a clinically necessity need, like a clinical need to do that. For GLP-1s, that's very, very small. But what we're seeing from some of these compounders, not all, but some of these compounders are skirting a real gray area and kind of putting this under personalization, where they're either changing the dose slightly, or maybe they're adding vitamin B12, but they're doing something to get around what's called that essential copy regulation in the FDA, so that then they're making it in mass, which is not the intent of that essential copy regulation. The intent of that is to maintain the sanctity of the FDA approval process, but then give a clinical need exemption to those few patients that do that. Unfortunately, there are a lot of these mass compounders now that made a lot of money, let's call it what it is, made a lot of money, and now don't want to not make a lot of money. And so what they're doing is they're trying to find these loopholes, these gray areas to personalize that medication and still make it in mass.
Thank you for explaining this. Ray, I'm going to turn to you. We understand that obesity impacts Hispanic Americans at much higher rates than non-Hispanic white individuals. How have you seen non-FDA approved medications for obesity, like counterfeit or illegally compounded GLP-1s, target your community?
Yeah, so I think, the Latino community and the African American community are kind of very similar in this situation. We have like about half the adult population of Latinos are obese, about 44 to 47%. And when you look at Latino kids, it's about 30%. So I would say it's a kind of the perfect storm. You have a high prevalence of obesity in adults and in children. In addition to that, you have a high level of underinsured or uninsured population. 1 in 6 Latinos are uninsured, possibly going higher in certain areas. Add to that, then you have a high number of folks going into the informal market, especially on the border states and in certain places like Florida or Texas, California, where you see literally these kind of U-turn places where folks are, it would say, it was like farmacias similares, like similar pharmacies, the same, you'll see the slogan, like the same but cheaper. And these are compounded, like kind of bootleg GLP-1s that are being made, counterfeit oftentimes. And so the adverse effects, if you see the percentage of spikes of adverse effects that are happening from 2019 to 2023, it's about 1,500% spikes in that. More than half of the adverse effects, folks that are being affected are Latino or African American. It's minority population that are being heavily affected by these adverse effects from fake GLP-1s. It is a huge problem. It is a growing problem. It is a problem that I think that we're seeing in communities. Again, the cost to go on Ozempic or Wegovy or whatever, it's like $1,300 or $1,000. If your insurance does not cover it, I mean, to pay out of pocket is a lot of money. And so if folks can find it, add to that another element for the Latino population is that I sometimes say we're like sponges for like misinformation. You see like apps, if I were to say something on Facebook or YouTube, it would be flagged in English as misinformation, But if it's the same information, misinformation being said in Spanish, the fact-checking devices don't necessarily pick up on it. So in many ways, that misinformation goes directly to that population. So advertising for certain types of certain companies that are actually highlighted in the report from Mr. Pitts, like that you're seeing this population be very vulnerable to this. And so I think again, it's that weird perfect storm of high prevalence, high underinsured, and then just being in localities where like or immigrant communities where there's kind of cash only or kind of informal sales of GLP-1s.
Yeah, thank you for explaining this. And you referred to the report that came out today. So this is from Peter's company, the Center for Medicare in the Public Interest.
Close, try again.
Oh gosh, Medicare, yes, sorry. The Center for Medicine, not Medicare, Medicine in the Public Interest. Thank you for correcting me, Peter. This report came out in the last 24 hours, published. It's a white paper that goes into great detail about this issue and how corporate compounders, as you call them, are still producing large volumes of compounded GLP-1s. For those of us who have not yet read your paper, can you go through the takeaways, please?
There's a quiz at the end of the briefing. First of all, thank you so much for the invitation to come speak in this lovely room. It makes the Switzer building look like the Waldorf Astoria. A couple of things that are in the report. Now, the report is a very legalistic, heavily footnoted report, and we have to have those types of documents because at the end of the day, if we're going to argue what the law says, what the regs say, it's important to know where to look for those and start as your baseline, which has not been happening to date. There are regs on the books relative to FDA and compounding, and a key point I want to make is I'm not suggesting that the FDA needs additional authorities. I'm suggesting the FDA needs to actuate on the authorities that it has now, which it is not. And part of that is philosophical, part of it is, as John alluded to earlier, the interesting tango the FDA has played over decades with compounding pharmacies. I believe compounding pharmacies are in fact incredibly important, John, just so that you know. But they also need the financial resources and the human resources to get that done. And as everybody in this room and watching online understands, that is a real issue and we can't skirt it. So a couple of points, and the report speaks for itself. The shortages of GLP-1s are over. Done. Finito. And if you want to argue that, here, or if you want to argue that in court or in the press, have at it. The FDA's grace period for stopping the manufacture and sale of GLP-1 compounded drugs was May 22nd. I know that because it's my birthday, which you all missed. So message number one, if you're thinking, well, maybe there still is a shortage and maybe there's some legalistic route around that, disabuse yourself of those notions. Second point, and I want to pick up on what Ray said. Since 2019, calls to poison centers for overdoses on GLP-1s have increased 1,500%. Coincidence or crisis? I don't believe in coincidences. And for communities of color who are disproportionately presenting themselves with these adverse events through compounded products, I would posit because they are not dealing with a healthcare professional who they can physically see and touch. When you deal with telemedicine, and telemedicine has many positives, but it also has the very disturbing reality of disintermediating healthcare professionals in the community, and that is not helpful. You mentioned my phrase of corporate compounding. The reason I say corporate compounding is when we're looking at GLP-1s, and I won't name names, but you know who you are, this is not about walking into your pharmacy and getting a medicine compounded because of a dye issue or because of a certain type of pediatric dosing issue. These are illegal pharmaceutical companies masquerading as corporate compounders. And initially, it was kind of cute and funny when we were talking about erectile dysfunction medicines. Now we're talking about more serious medications. We're talking about needles and vials. I saw an ad in the newspaper yesterday that talked about, you can get these compounded, personalized products, and the wording was very smartly done. They didn't say GLP-1s. They didn't say obesity, but the visual was a hypodermic needle and a bottle. So, a picture is worth 1,000 words, all of which are out of compliance. You cannot personalize a product for millions of people. Now, if you want to dig into the report and look at the 5% rule, or just Google FDA 5% rule, it's crystal clear. So every pharmacy is state licensed. A pharmacy licensed in, pick your state, Indiana, cannot sell more than 5% of what it compounds for its brick and mortar customer base. Gee whiz, have we forgotten about that? What's going on here? We've all spent a lot of time talking about the dangers of illegal, unregulated drug importation. Just because a importation site has a Canadian flag on it with a white guy in a white coat does not mean that's where the drug is coming from. Similarly, with compounded products, and especially GLP-1 products, where is the API coming from? Where are the factories that are manufacturing these products? Sometimes we know, sometimes we don't. But what we know for certain is that these products and these factories, whether it's the API or the finished product, are not inspected, reviewed, and tested by the FDA unless and until something bad happens. So the question we have to ask ourselves is, with all these people using all of these compounded products, and access clearly becomes an issue, how many bodies do we need before we recognize the problem? A 1,500% increase in adverse events is not something that we can simply wave away. I talked about marketing. Let me tell you this. I live in New York. The newspaper I read every day is the New York Times, in print, because I like doing the crossword puzzle. When did all the news that's fit to print become all the checks that clear? Where are these standards and practices attorneys at newspapers, at magazines, on networks that aired the Super Bowl, saying, are we liable for airing these ads? No fair balance, no adequate provision, nothing. Now there's a FTC angle here, which I won't go into unless you want to talk about it. But the fact of the matter is there are a lot of people making a lot of money off of this, and it's irresponsible. And it's especially irresponsible, I think, for newspapers like the Washington Post and the New York Times who are reporting on this issue to benefit from a very sleazy type of proposition here. Lastly, John mentioned personalization. Personalization is really important because the argument is, oh, compounding can go beyond shortages. Compounding can exist because of personalization. And John did a very nice job explaining what personalization is and what it is not. But when you add a B12 vitamin to a GLP-1 product and say, well, that's personalization, that's not personalization. That's not single patient personalization. It's illegal and misleading brand extensions. Large-scale compounding of GLP-1s is a big business. It is not regulated by the FDA. It is going to cause huge problems. And if we wait until people have serious adverse events and have serious issues with their health, shame on us. There's a great French proverb that translates as, greedy eaters dig their graves with their teeth. So I would argue that the large corporate cowboy compounders who are out there now have bitten off a lot more than they can chew. Thank you.
Thank you, Peter. That was a great overview. For everyone who hasn't read the white paper, you can learn more about everything that he just went over. Peter did a great job talking about the repercussions of mass compounding, or potential repercussions of mass compounding. John, I'm going to turn it back to you to elaborate on this, please.
I have a number of concerns. I mean, one of the big ones is I just said that compounding is essential to pharmacy practice. I don't want the bad actors out there, the bad apples, tainting the bunch, because compounding is essential, and making sure that it stays essential is really important for pharmacy practice, both in the community and hospitals and health systems. That said, we need to continue to prioritize science and safety over convenience and cost. How many of you in this room like your drugs to be, or medicines to be, safe and effective? Yeah, me too. And I'm not saying compounded drugs aren't always, but what we're risking here, to be honest, and you've probably seen it in your news feeds, on your socials, is now you have some of these kind of fringe or outlying or other compounders who are trying to just prioritize profits. And what they'll do is now make an oral tirzepatide, a sublingual tablet, things that have not been proven to be safe and effective. And where does it end? With GLP-1s, with other medications? If I can just make whatever I want, sell it direct to the consumer via the internet, it completely erodes the regulatory framework that we've built over hundreds of years because we had snake oil salesmen doing this exact same thing. And so that's why it's really important to get out in front of this, to very clearly delineate what is clinically necessary and what isn't, prioritize FDA-approved products when we can, and use compounders only when it's absolutely necessary. There are plenty of examples. I don't have time to go through it all here, but just recently, a med spa in Colorado, Thrive, recalled 1,300 syringes of their compounded, I'm using air quotes for those who can't see me, tirzepatide, which was made in a non-sterile room with people that weren't even wearing sterile equipment, just mixing it together and hoping for the best. And they're not alone. That's a patient safety issue. And again, that gives compounding a bad name. So yeah, please.
One other thing that makes a difference between a legal, regulated pharmaceutical company and an illegal, unregulated pharmaceutical company, i.e. large-scale compounding, is that regulated pharmaceutical companies actually, if that's my mother, tell her I'll call her back. Illegal pharmaceutical companies don't have to report adverse events.
Yeah.
Oops.
It's a huge gap in the patient safety system. And if you go back to my example of making different formulations and making sure that they are of both safe and effective in reaching that regulatory threshold, there's a process for that. It's called a IND, investigatory new drug application, and an NDA, new drug application. There is a framework to ensure that your product out there is both safe and effective. So if you're going to go that direction, by all means go that direction, but use the framework that exists to ensure that the medicines that are in my supply chain are both safe and effective. If left unaddressed, and it's a matter of time, and I've been doing patient safety work for so many years, unfortunately, it's when the really bad stuff happens that action gets taken. And we'll take the New England Compounding Center as an example in Massachusetts, where due to sterility issues, API issues, a lot of bad decision making, bad practice, over 100 people died from the products that were distributed by New England Compounding Center. Unfortunately, that now happened kind of a little bit too long ago, where the memories fade until the next issue happens. And that's unfortunately how safety sometimes works. I don't want anyone to get harmed, which is why we're having the conversation now.
Thanks, John. So what can the FDA do about this?
I think Peter hit the nail on the head. Is the FDA has the policy necessary? They have the actions necessary. They just need to do it. They just need to actually enforce, use their ability to take action on these different bad actors so that compounding everywhere doesn't get a bad name, but they also need to be resourced appropriately. We need to make sure that the FDA has the resources they need to actually take action, collaborate with the states when necessary to ensure that we're shutting down these risks to patient safety.
You know, when the FDA does not take action, and we can certainly kind of discuss whether there's some political aspects to that as well. When the FDA does not take action, when consumers see advertising in very high-end newspapers and magazines and on network television and online all the time, they think to themselves, well, it must be okay because they wouldn't be doing it if it was illegal. That's what happens when you have, I don't even want to call it regulatory discretion, simply regulatory neglect. And that has to stop. And the FDA has a bully pulpit. When the FDA takes action, it's news. When the FDA is the cop, it's news. And the FDA needs to step forward and, for example, publicly call out the New York Times and the Washington Post and television networks saying these ads are illegal, you shouldn't run them. These companies should not be selling their products in the quantities that they're selling. They're not compounders, they're illegal pharmaceutical companies. Now, if you go to the FDA website, to John's point earlier, all this is spelled out very clearly. If you read this report, the report that we released today, we go into that. But silence is not consent in this respect. It's simply neglect.
Thank you for explaining this. Can you get into the misleading marketing a little bit more and what can be done about the misleading marketing?
Sure. So GLP-1s, pick your favorite FDA-approved brand, are RX medicines. They're prescription medicines. They can only be prescribed by a physician. Compounded GLP-1s are not reviewed, approved, or tested by the FDA. They are largely prescribed through, I don't want to give it the patina of confidence by calling them telehealth companies. You go online and answer a few questions. A doctor doesn't speak with you, generally speaking. You're not always asked to, there's no checking with your primary physician through medical records to find out what other conditions you might have. So these medicines are being dispensed theoretically through an RX perspective, but realistically, these corporate compounders are bastardizing telehealth by disintermediating not just a local healthcare professional, but any practical ways to catch errors. A lot of times, people take medicines, as you know, and certainly in the Hispanic and many other communities of color, people don't know, and certainly with the elderly, what type of medicines you take. Well, there's the blue one, there's the red one, there's the white one. People don't know what they're taking. They don't know the dosage. They don't know what the side effects can be, or the drug interactions. There's no way to catch these problems, so there's no surprise when adverse events skyrocket and calls to poison centers skyrocket. Also, people who are getting drugs online. And this is as true for GLP-1s as it was back in the day for antidepressants and erectile dysfunction drugs. They know they're dealing with shady enterprises. They know they're skirting the system, and they're embarrassed. But we have to somehow, as you mentioned earlier, get beyond the embarrassment of needing, for example, to go beyond the labeled indications of diabetes, and high blood pressure, and cardiovascular risks for people that really want to lose weight and could use some assistance in doing that pharmacologically. They shouldn't be shamed into using non-legitimate sources.
Yeah, thank you. We have time for, I think, one more question before we open it up to the audience. So if you have questions, think about them now, since we'll be ready for you shortly. I'm going to end with Ray. If you can tell us a little bit more about how your organization is advocating for access to safe and affordable FDA-approved medications. You touched on it a little bit before about how, we're so fortunate to be in a place in, the field of obesity medicine that we finally have medications that are highly, highly effective. But there have been so many barriers in terms of cost, insurance coverage, too few providers, shortages until now. What are you doing in your community to advocate for improved access?
I think one of the biggest challenges that we face is the coverage of access for GLP-1s for Latinos and for African Americans, for other minority communities. But so the Treat and Reduce Obesity Act is something that we pushed very heavily last year. We're doing it. It's been reintroduced again this year. We're again trying to push that forward as well. Trying to just educate folks on the Hill about having coverage. So GLP-1s are covered by federal health employees. That are covered by the VA. It's not covered by Medicare, or it's not covered by well, in some states it's covered by Medicaid. When President Biden, I think it was the day right before Thanksgiving. It was like November 26th. He proposed a proposed rule to include GLP-1s in Medicare and Medicaid. And then on April 4th, the Trump administration decided that they were not going to go in that direction. With that, now a lot of states are moving away from this. Like if they had coverage of GLP-1s in their state Medicaid, California, New York, Delaware, Connecticut, you're seeing state after state after state, North Carolina, moving back, not saying if they were covering GLP-1s in their state Medicaid or state health state employee health programs 2 years ago, now they're not, and so you're seeing that rollback. So again, the number one thing is if we can get folks getting covered, that's a huge issue. On the misinformation, like we can complain, about being sources of being targeted by misinformation by bad actors, but we can also flood the zone with correct information. So that's one of the things we've been trying to do is in our social media, on all platforms for Latino organizations, we're the highest, most followed Latino organization, if not the second most highest, depending on the platform. So putting content, just daily content, building a following, just getting information out there. The League of United Latin American Citizens is the largest and the oldest Latino civil rights organization. We've been around since 1929. About, if that's my mother, I'm just like, that joke. So if So we have about 325,000 members across the country. So one of the things we've been trying to do is on certain days to try to go into local media markets, especially Latino media markets, and try to talk about it. It really, as Mr. Pitts points out, like FDA, that regulatory mechanism really does matter a lot. But we still try to push states as well, having dashboards of recall batches, having dashboards of bad pharmacies, things at the state level. If the feds are not doing it, to have the states try to push that as well. So but of course, a lot of the states are relying on the feds to do that, and so it really kind of falls onto the FDA to do that. And again, just trying to correct the wrong information through social media, using our councils in locally to try to go into local media as well, and then advocating statewide and nationally for coverage for GLP-1s. That's been kind of our big solution to this.
You know, one thing Ray said I think is worth kind of just going down that path just for a second more is when federal authorities, FDA and other authorities, don't take strong positions relative to regulatory authority and safety issues predominantly, you begin to have states thinking, gee, I wonder if we could buy these compounded drugs and use them within our state Medicare and Medicaid programs. Very, very bad. Because then what you're doing is redlining the Medicaid and Medicare communities to unsafe, untested, unregulated drugs. And that's the shonda.
Thank you. We are opening up to questions. We probably have time for about 2 or 3. Feel free to go ahead and raise your hand. Okay, yes.
Want to turn off your phone first?
Yeah, if cost and access are one of these driving factors towards these non-legitimate drugs, how can this be addressed through maybe PBM reform or like the cost regulation side of the GLP-1 market?
I mean, PBM is a fascinating conversation.
Hang on one second. I'm just going to repeat the question in the mic. So great question. If cost and access were not an issue, or sorry, looking at cost and access as being such a big issue, what can we do about PBM reform and cost reduction? Great question. We need to have another briefing about that. But Peter, go ahead.
I was going to say we need to have a briefing on that. But, you know, a couple of years ago, Senator Mitt Romney had a hearing with drug manufacturers, and he said, you know, if we disintermediated the PBMs, how many of you could lower your price by half? And every hand went up. And then the PBM Association said, well, you know, it's not that simple. It's really super complicated. But the answer is that, you know, the more players you have taking their cut, and we're talking about billions of dollars worth of cut, those are savings not passed along to the consumer.
And just to add, I really appreciate that question. And we could have an entire symposium on this. And, you know, drug costs in this country are a problem. It's not just GLP-1s, it's pretty much every category of medicine. But, you know, the thing about access is I'm all about access. I don't like people hiding behind access as a reason, because access to crap isn't great either. So just saying access is not enough. It's access to those products that are both safe and effective. And sometimes, unfortunately, that might come with a higher price tag, but you know at least what you're accessing is the real thing, legitimate, safe, effective.
Thank you. Go ahead.
Yeah, you state here that the poison control, increase in poison control calls as an example of compounded drugs being unsafe, but you don't provide any comparison between the increase in calls related to approved drugs versus the increase in calls related to compounded drugs. And I would also say that the rise of the use of these drugs since 2019, I believe, is significantly more than 1,500%. So isn't that an indication that there's actually less calls than there were before?
No, it means there's more.
Hang on a
It means there
second.
are 1,500% more.
As a relation to the amount of drugs circulated in the business.
Well,
I'm just going to repeat the comment, the question. So the question is that we talk about the increase in poison control calls going up by 1,500%. This is for compounding, but we don't compare that to the approved medications. The use of compounded medications since 2019 has gone up by more than 1,500%. So what is the discrepancy, Peter?
So I think that the key point to kind of look at this to your point deserves a deeper dive is who calls poison centers versus who calls their physician. Generally speaking, when a patient has an adverse event because of the medicine that they were prescribed by their physician, they either go to the ER or they call their physician. When they're getting their medicines from someplace other than a known physical healthcare professional, those are oftentimes the calls that go to poison control centers. But your point is well taken. That really deserves a deeper dive, and it speaks to the point that we need to be able to kind of extrapolate and create some type of an algorithm that shows for companies that aren't required to report adverse events, what should their adverse event profile look like?
I'd love to see them compare the calls and the issues created by branded drugs and the calls and issues created by compounded drugs, because I haven't actually seen that as someone who is in that business, that there's any wild increase in safety issues.
I'm going to call on Joe.
Yeah, thanks for calling me, because I was thinking about a policy solution to your question that you had right there. And I think one of the things that we do not know is how many people are taking compounded medicines.
Yeah.
So wouldn't a simple regulation that requires a 503A pharmacy report, how many prescriptions they've issued, or a 503B pharmacy report, how many bulk prescriptions they've taken,
That-
be a policy solution that we all should think about, because then it lets us actually frame out, okay, now we know the scale, and then we can do those comparisons.
And that's capturable data.
Capturable data, right? I think that we lack some data.
Which, by the way, we have asked the FDA for that very thing for years.
Yeah.
Years, and they refuse to do it.
Right.
I'm sorry, could you tell us who you are?
I'm sorry?
Your name?
My name is Dan Denai.
And you're with?
I'm with Pharmaceo Custom Compounding.
Yeah, so I think for me, I think that's just thinking about potential, like how do we scale this out again? Because we hear lots of numbers here. Trust me, I don't think there's anyone in here who does not have a social media feed that's trying to sell them a compounded drug, no matter your body size right now. Seems like everyone we know is on these medicines, but we don't actually have any idea.
One of the things that Commissioner McCary has talked about, which I think is legitimate, is the enhanced use of AI for various things. And generally speaking, so social media is a good example. My belief is, like just with any pharmacovigilance issue, where there's smoke, there's fire. And not every comment on a negative result is a adverse event, but it would allow us to begin to capture what the general themes are out there and what's generating them.
So I know we could continue for hours and hours and hours, and I'm sorry to all the people who have their hands up, but we are unfortunately at time. Thank you so much to everybody here for joining us today. The Obesity Society will send out a recap report from today's briefing, and please reach out to the Obesity Society or any of the experts if you have further questions. Thank you so much.
Well done.